I am excited to present my project that I worked on during my 5th year off on research, which I titled Co-Targeting of TrkA and RET Pathways in Breast Cancer Brain Metastasis. I worked in Dr. Lowe's lab. We all have met her multiple times, especially at that last retreat that Dr. Morcos coordinated. She's a professor here, and I worked with her and Dr. Regua, who is in her lab. And their lab focuses on breast cancer brain mets, GBM, and aberrant cell signaling and targets for therapies. It's a lot of fun working with them. I worked on a very highly translational project on breast cancer brain metastasis. Just briefly, I wanted to go over background. Brain mets, of course, we all know this, that they're the most common cause of intracranial neoplasms in adults with invasive cancer. 25 to 45% of cancer patients are diagnosed with brain mets. They're more common than primary brain tumors and a major cause of mortality from brain tumors. The annual incidence is going up every year for new cases of mets due to patients living longer from primary cancer treatment, enhanced diagnostic ability, and the fact that most chemo still does not reach the brain, providing a safe haven for cancer cells. Breast cancer is the second leading cause of cancer-related deaths in American women. There's 5 major clinical subtypes, the triple negative being the worst or conferring the worst prognosis due to lack of targeted hormone therapies. And breast cancer brain mets represent a therapeutic challenge because of redundant signaling pathways and a lack of targeted therapies capable of penetrating the blood-brain barrier. As we know, the standard of care is still surgical excision and radiation, and there are little or effectively no targeted molecular therapies. They play a very small role due to the inability of them to penetrate the blood-brain barrier. So in my project, of course, this is a cancer biology lab, and we're working on basic science research. So I want to introduce to you the first protein I worked with, which is called TrkA, or tropomyosin receptor tyrosine kinase A. This is a receptor tyrosine kinase, a member of the TrkA family, which is known for its role in neuronal differentiation and survival, synaptic strength, and plasticity in the nervous system. TrkA-mediated cell signaling is integral to cell survival, proliferation, growth, and synaptic plasticity. And TrkA fusions have been identified as oncogenic events in several cancer types already, including GBM, thyroid cancer, and breast cancer. There are several pan-TrkA inhibitors that are currently being tested in clinical trials and are receiving FDA approval. And this is a figure I've taken from one of the papers written by our lab, showing the TrkA family, and TrkA is the one that I focused on. Its cognate ligand is beta NGF, and when it binds, the protein dimerizes, it autophosphorylates, and then propagates several oncogenic pathways. As I alluded to earlier, there are several TrkA inhibitors. I want to point out 2 of them, entrectinib and larotrectinib, which are pan-TrkA inhibitors with enhanced selectivity for TrkA. They both have FDA approval for NTRK gene fusion positive solid tumors. And they are both currently in multiple clinical trials for tumors with NTRK altered tumors, ROS1 or ALK1 fusion. And entrectinib is also in a clinical trial for combination treatment with endocrine therapy for lobular breast carcinoma. And interestingly, entrectinib has actually shown blood-brain barrier permeability in trials with 55% intracranial response rate for patients with metastatic non-small cell lung cancer. So that was interesting to us because, as I said, we were looking for treatments that do penetrate the blood-brain barrier. So our lab published this paper last year titled Dual Inhibition of the TrkA and JAK2 Pathways using entrectinib and paclitaxel suppresses the growth and metastasis of HER2-positive and triple-negative breast cancers. And in this paper, we showed that TrkA monotherapy decreased brain metastatic burden, but it did not completely abolish it, as you can see in panels D and E. So the next steps that we wanted to do were evaluate potential co-activation of TrkA with another receptor for co-targeting and treatment, since monotherapy was not effective alone. To do this, we looked into the TCGA database, which is a publicly available database of breast cancer patients' molecular information. And we screened for receptors with signatures that correlated with the TrkA activation signature. And we found that RET was highly significantly correlated with TrkA. This was also validated using the GEO database, which is a similar publicly available database. And I showed a very strong positive correlation between TrkA and RET, thereby showing that there's potential co-activation of these 2 pathways in breast cancer patients. So RET is also a tyrosine kinase. It's a transmembrane receptor tyrosine kinase. Its cognate ligand is GDNF. And when it binds, it also dimerizes and autophosphorylates. It plays a critical role in embryonic development of kidney and enteric nervous system. Alterations in RET have been identified in numerous cancer types, and it has an established role in oncogenesis already, in thyroid cancer, non-small cell lung cancer, breast cancer, salivary gland cancer, prostate, colorectal cancer. There are several selective RET kinase inhibitors, two of which I want to highlight, pralsetinib and selpercatinib. These are both orally available selective RET inhibitors. Pralsetinib in the ARROW clinical trial actually showed 78% intracranial response rate in patients with metastatic non-small cell lung cancer. Selpercatinib in the Libretto trial showed 80% intracranial response rate. They both have FDA approval for metastatic RET fusion positive non-small cell lung cancer and thyroid cancer, and they're both in multiple ongoing clinical trials. Due to their intracranial response rates that we've seen, they were of interest to us. So after we identified RET as potentially correlating with TrkA, we wanted to see if these two pathways were co-activated. So we used immunohistochemical staining to analyze 15 patients' matched samples of their primary tumor and their brain metastatic tumor tissue taken from the same patient. And we stained them for activated RET and TrkA. And we found that the staining intensity was significantly higher in the breast cancer brain met tissue compared to the matched primary for both activated RET and TrkA. We also found that 13 out of 15 samples of the brain met samples were stained highly for both RET and TrkA, which was statistically significant. And here I have a representative image of some of my IHC slides. You can see that the primary tumor did stain for both activated RET and TrkA, but the staining was much more intense in the breast cancer brain met samples. When we correlated the staining for all of my samples, we found that there was a significant correlation between the H-score or the IHC score for TrkA and RET, suggesting that there is pathway co-activation. We further analyzed our IHC samples and looked specifically at the triple-negative breast cancer samples. As I said, that subtype confers the worst prognosis, and there's no hormonal therapies for those patients. We saw a similar trend. 6 out of 7 patients had brain met samples that stained highly for both pathways, and the brain metastatic tissue stained higher for both RET and TrkA. It was statistically significant for RET, trended for TrkA wasn't significant, but the sample size was very small. Going back to the TCGA database, which I told you was a publicly available database, when we split patients into different subtypes, we found that the RET and TrkA pathway signatures, both individually and in combination, were significantly higher in patients with the triple negative subtype compared to luminal and HER2, which makes it interesting because if this is a potential therapy for patients with triple negative subtype, then that's something that should be looked into. Since we saw increased staining in my IHC samples for activated RET and TrkA in the brain met tissue compared to the primary tumor, we wanted to see if there was a difference in the gene activation signature as well for the two pathways in patients who had brain relapse versus those who did not. And we found that both the individual and combined signatures were significantly higher in patients with brain relapse versus those without. This was seen both when you excluded patients with other organ mets and when you included patients with mets at other sites. The signatures were higher in patients that had brain relapse compared to those that did not. Not only was the gene activation signature higher in patients with brain mets, we also found that the patients with higher combination signature had worse overall metastasis-free survival. And the difference is pretty significant at 38 months versus 66 months here in the high TrkA RET combined signature versus low. If you stratified individually and you took just patients with low, 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 high, high, low, and high, high, the same pattern is seen. The red bar here indicates patients with the combined higher signatures. Clearly worse overall metastasis-free survival. And this was true also if you look specifically at brain metastasis-free survival, which is of course what I'm more interested in. The co-activation of the two pathways conferred much worse brain metastasis-free survival of about 70 months versus 96 months, which is a pretty big difference. So finally, we further validated whether these two pathways were co-activated using Western blot analysis of breast cancer cell lines. We used 3 different cell lines, SKBR3, which is a HER2 cell line, and then the CN34 and MDA231 cell lines, which are triple negative. We compared the expression of activated RET, which is PRET, and activated TrkA or pTrkA in these parental cell lines to their brain tropic counterparts. The brain tropic cell lines are created by serially inoculating intracardiac in mice and isolating cells that metastasize to the brain, and they do it multiple times and then isolate those cells. So that's how you get the brain tropic cell line. And we found that the activated RET is much more highly expressed in these brain tropic cell lines. So SKBRM is brain tropic versus SKBR3. Clearly, you can see that activated RET is much more highly expressed in these brain tropic variants compared to the parental variant for all 3 cell lines. The same trend is seen in activated TrkA. I know it looks less impressive, but it is still there. So this was very interesting and kind of further validated that co-activation, specifically in the brain tropic cell lines. So now that we established that these 2 pathways are co-activated and highly expressed in patients with brain mets and confer worse prognosis, this justified us looking into co-targeting and inhibiting the 2 pathways. So we started by performing cell viability assays to see if inhibitors for the 2 pathways would synergize to reduce cell viability. We started with IC50 determinations of the drugs that I introduced previously. We picked entrectinib as the TrkA inhibitor and pralsetinib as the RET inhibitor, using the same 3 cell lines because the IC50s were lower. These 2 drugs required very high doses to in their IC50 determination, so that's why we picked entrectinib and pralsetinib. And we performed cell viability assays, which involves seeding cells in 96 well dishes and then treating them with the combination drugs at different ratios and looking at cell viability after 48 hours. The data is inputted into a computer system, and essentially you get these CI values, which are combination index values. A CI value of less than 1 indicates synergy. If it's equal to 1, it indicates that the drugs are additive, and then greater than 1 indicates an antagonistic effect. And you can see that for all 3 of my cell lines, at all the different ratios, the 2 drugs were synergistic, and if not synergistic, at least additive in their effects. And this is a graphic representation of the same thing. Orange bars here in all 3 cell lines indicate the combination treatment group, and you can see that the cell viability was significantly lower in combination compared to individual and vehicle treated groups. So we also did the opposite of cell viability, which is cell death, and we did an annexin 5 flow cytometry assay, and we found that co-inhibition enhanced apoptosis of the brain tropic cell lines. So this is 1 cell line, CN34 brain. The green bar indicates the combination treatment groups, and you can see across both 48-hour treatment and 72-hour treatment, there was higher early, late, and total apoptosis in the combination treatment groups compared to individual and vehicle treated groups. That was cell viability and cell death. Another property of aggressive metastatic tumors is that they're highly migratory and invasive. So we performed a migration assay, which involves seeding cells in a petri dish, inflicting a wound, literally just a wound across the petri dish. And then after 24 hours, you image the dish and you see if cells migrated across the wound. And I did 2 different cell lines, and we treated, as with vehicle, individual, and combination treatment. And you can see that the combination treatment, or I'll start with vehicle, the vehicle treatment, the cells clearly cross the wound as we would expect. They're not getting any drug treatment. The individual groups, individually treated groups had decreased net migration rates, but the combination treatment group had significantly decreased combination migration rate in the CN34 brain cell line. It trended lower in the 231 brain, though not significant compared to pralsetinib alone. But I think the images look very nice and show that there is this trend towards decreased migratory capacity with combination treatment compared to individual treatment. So these in vitro studies provided enough rationale for us to proceed to an in vivo study. And we wanted to see if the combined treatment with TrkA and RET FDA-approved inhibitors reduced triple-negative breast cancer tumor growth in vivo. We performed intracranial inoculation of the 231 brain cell line, and then began twice daily oral treatment of the vehicle, individual drugs, and combination drugs, and then imaged the mice to see tumor size and tumor growth. And these are just pictures of the mice at 25 days. You can see my combination group did, unfortunately we had to terminate early, which I'll show you in a second due to toxicity. But we still took data from the individually treated groups, and the trend you can see for tumor size to be significantly lower than vehicle, though ultimately as the days progressed, the tumors did start increasing in size in the individual groups, which we kind of expected. And the hope was to see that the combination group would stay flat. This is ex vivo imaging, which shows effectively the same thing. So the combination group, I said we had to terminate early. We did manage to collect some samples from them. And the suspicion is that they experienced liver toxicity. You can see that their ALT was higher compared to the vehicle and individually treated groups. I suspect that this is because entrectinib is a weak CYP3A4 inhibitor and pralsetinib is a time-dependent inhibitor of CYP3A4. So I think dose adjustments just need to be made to decrease both doses of the drugs for these mice. And another study hopefully will be done so that to show what that combination group might look like, and hopefully would show a more flat bar in terms of tumor growth. So after having seen all this co-activation of the two pathways and treatment synergy, the question remained, what is the mechanism behind this synergy between these two pathways? And there is a previous paper that's been published in neuroblastoma research, which has shown cross-activation of these two receptors, but it didn't look further into the mechanism. So we wanted to see if we could see this same cross-activation in breast cancer cells. So we stimulated cells with the cognate ligands, NGF and GDNF, and wanted to see if we could see cross-activation effectively. And we found that treating with the ligand NGF, which is for TrkA, of course, that increased the activated TrkA levels, but it also increased the activated RET levels, and vice versa. Treating with GDNF increased activated RET, as we would expect, but it also increased activated TrkA. So this was very interesting. This is the first time that this finding has been seen in breast cancer cells, and is very novel for breast cancer research. So we took this a step further and looked at cross inhibition with treatment of the two FDA-approved drugs that I worked with previously, entrectinib and pralsetinib. We expected to see a decrease in the, with entrectinib, we expect to see a decrease in activated TrkA. We wanted to see if that it would show also a decrease in activated RET, and we saw that. So with entrectinib here in the second column, activated TrkA goes down, but so does activated RET, and vice versa. With pralsetinib, activated RET goes down, so does activated TrkA. So this was very interesting and very novel, and it indicates that there is clearly some sort of signaling crosstalk between the two pathways, but it doesn't tell us exactly how that's happening. So we performed an assay called the CETSA, or a cellular thermal shift assay. And in this assay, we transfected cells to overexpress either RET or TrkA. Then we starved them and stimulated them with ligand, both NGF and GDNF. Then we heated the suspensions at different temperatures. The idea is that proteins degrade at higher temperatures, but if a protein is bound to a ligand, it stabilizes. So beta-actin is the loading control, and as you can see, beta-actin decreases in expression over higher temperatures, it degrades. That's what we expect to see. Now, TrkA clearly stabilized, expression was stabilized with the addition of NGF. That's what we expect. That's its cognate ligand, but it also stabilized with GDNF. The question comes up then, is the ligand we're adding, we're stimulating with ligand, is it just binding any receptor, like transmembrane receptor? So we did go ahead and look at another transmembrane receptor, VEGFR2, and you can see that that does actually still degrade. So it's not that we just overstimulated with a bunch of ligand and it bound to all kind of indiscriminately to all proteins. So this was really exciting because it suggests that there's possibly a direct ligand binding interaction. And we did the same for RET, where same assay. We saw a stabilization of RET with the addition of GDNF. This is expected if that's its cognate ligand, but it also stabilized with NGF. Beta actin degrades as we expect, and VEGFR2 still degrades as we expect. So, in conclusion, the TrkA and RET pathways are co-activated in breast cancer brain metastasis patients, and this co-activation confers a worse overall metastasis-free survival and brain metastasis-free survival. These two, the TrkA and RET inhibitors synergize to reduce cell viability, enhance apoptosis, and decrease migration in breast cancer brain tropic cells in vitro. And signaling crosstalk between the two pathways is possibly mediated through cross-ligand interaction. There's still a lot of further studies that we need to do that I had started working on before I had to leave. Markers of apoptosis, like the PARP assay, we had started working on just as I was leaving, as well as an invasion assay to see if combined treatment decreases the invasiveness of tumor cells. I had looked at migration, but I didn't have a chance to do invasion. I think that the animal study needs to be repeated with just a dose adjustment for the combination therapy group. And then further studies just to look at to determine the interaction between the TrkA and RET proteins and the mechanism behind that. And then finally, of course, the ultimate goal would be to do a clinical trial for a combined TrkA and RET inhibitor treatment in patients with metastatic breast cancer. Really thankful to my two primary mentors, Dr. Lowe, Dr. Regua, and then everybody else in the lab who helped teach me how to do all these experiments. I didn't know how to do any of that before I started. And my clinician mentors, of course. This is a picture of our lab, and I had a lot of fun during the year, and I learned a lot. So.
I have a question. So it was incredible. You did, amazing time in the lab. It would have been awesome, obviously, if the combination treatment line had stayed flat and the animals would have been safe. What I found in my lab experience is the same thing, and that's kind of jazz. I hope you all remember that when I present mine. But if you think the next best step is just adjusting the dose, is there any other thoughts on if that doesn't work, what would be next? Or
so I think there are other inhibitors. So I'd have to look in to see if I think most of the inhibitors still go through the CYP3A4 pathway, but if there's one that doesn't, that would be potential next step is just to use another inhibitor that we know also works. These are all FDA approved in humans already for other types of cancer, so that's nice because we know that they're safe to use at least individually. They just haven't been done in combination. So we have to make sure that the doses are adjusted appropriately so that people don't get liver toxicity, of course. Yeah.
Shivani, as you know, of course, this is a huge problem in the small subset of women with metastatic breast cancer who are negative. Yeah. Or even sometimes who do have some programmable receptor. They develop carcinoma meningitis. They develop horrible disease that is CNS restricted. Right. And the disease is well controlled elsewhere. They still die of CNS mets. Where do you think, given that these drugs are actually on the market, how, what should we have any reluctance in just using them?
Meaning without clinical trial or starting clinical trials.
Yeah. I think even outside of a clinical trial, you do a clinical trial. Yeah. A drug is you're seeking indication. Right. But another way of getting to this is sometimes treating a handful of patients on a humanitarian basis.
Yeah,
and showing that there's a response, right? And then you have a much more compelling story for IRBs and FDAs and everybody else. You have that data, even if it's in just a handful of patients.
Yeah, I think that what really helps is this project is using already approved drugs that we know are safe and are being used already in non-small cell lung cancer patients metastatic to the brain. And it's already shown really great response rates. So I do think that if we know these patients have higher RET activation and TrkA activation, it's worthwhile. It's really worthwhile to go ahead and proceed with treatment.
So what I'm saying with this is, most oncologists don't think of cell line of origin. They
Right.
have targetable mutations.
Right.
Are there any case reports of people having tried it already? You know, why wouldn't you if you had a patient with metastatic breast?
They're already starting to try to use these drugs, not in combination as I've worked on, but individually, there are some trials of patients with breast cancer that are getting these drugs. But the main issue is, as I showed, these drugs aren't working in monotherapy. And that's the question is, there's clearly redundant cell signaling, and how do we target all the pathway so that it just ends rather than, just going through a different pathway. So that's why I think, although it's less interesting to us, the mechanism behind these pathways working together and what, how that happens is really important to understand. And it is really what I think validates using combination drug treatment, because clearly we tried using RET monotherapy and then the TrkA it doesn't, at least in the animal studies, is not effective enough. It has an effect, but it's not good enough. And as you saw, the bar started going up with tumor size after just 25 days in the mice. But the idea is to keep it flat and actually have like this, good treatment response. So
Yeah, but they're mice.
so they're mice. I know that's different.
These are xenografts.
And humans have had good response rates in non-small cell lung cancer. So.
Right. So what I'm trying to get at is, there's many paths to research here, and you can go through the very systematic path, doing all the animal trials, and then fail in the human.
Yeah.
Or you can fail in the human upfront.
Yes, especially since I know what you're saying, especially since we know that these drugs are already safe for humans. So I think that's a good point. Yeah.
Are you done with this now?
So, well, the project is continuing in Dr. Lowe's lab. I'd like to. I mean, it was, yeah.
Okay, my question is, are you, do we have?
I think the main thing here was I have never done this kind of work before. So it was a big learning curve for me. I didn't know how to do any of these assays. So I think now that I've learned this, it's actually feasible for me. Before this, I didn't think it was feasible for me to do any kind of bench work or guide any kind of lab research project. But now I've seen that it was very educational. And I think it would be nice to continue some kind of work like this, whether it's not in this exact same project, but it's something that it's now feasible for me because I've learned how these things are done. And it takes a lot of time and effort. These assays are really hard. So
any comments, Chris, about, as we go to how we can shape this to give her that benefit for an academic promotion? Is this something we got?
Well, look, I mean, we can obviously do 2 or 3 things, right? One is, we can support you even in the next year or so with a technician to keep doing the work, as long as you are still going to be heavily involved in the project, right? Just like with Laura, same aspect here. It has to be very clearly defined what that person's going to do. They're not going to be general purpose for the lab that you were in. And if that is, helpful, sure, but it has to be part of that trajectory that for you to go into academics, to do fellowships, and you have to come to us with that. Well, this is what I want. This will really help me.
yeah, I mean, I started this project from the beginning. So this is something that I'm very invested in and I really love working on it. So if there's, support, I can talk to y'all later about, support for me to continue that kind of work. But yeah.
I mean, we've supported residents with research assistants to carry on work as their PGY7 year. So that certainly is available. And, I will say that, that this working in the lab has a lot of benefits. And one is to get some publications, but the other is to learn techniques that, will carry you on for research long-term, whether you publish, a Nature article or not. And it really changes your ability to act as an academician, interact with research faculty, learn how to think like they do, design animal experiments. And so all that is so important. And so it's a worthwhile endeavor, and really immersing yourself into that is so beneficial. Yeah, we can certainly look at continuing to support this. There's mechanisms and continuing to do some work. There's transitional grants. I think at K99 or K01, you know that mechanism?
Sure, yeah, there's a variety of different mechanisms. And, there's also, as you know, there's a K12 that is specific for young neurosurgeons. And, you know, I think,
We should maybe look at some of those grants, because if you get grant funding, that opens up doors for getting research assistants too as well. And so you can submit for these kinds of grants. They're just transitional grants, high-level training, early faculty grants.
but, you know, grant submission and funding and all that is a long cycle. I mean, none of the residents who are chiefs either have the time or the, you know, it's very unlikely. Unless you've already, in our ecosystem, if you had an R25, you could get a second increment for your PGY 7 year. NREF would be the other option, but, you know, what I'm getting at is that, but when you reach this point and you're at this fork in the road, you've had a good lap time, it has to be very clear to you what you want to do with your career. Right? That is the entire point of this year. It's supposed to be transformative for those who've never done research and really, really, you know, a massive CV builder for those who have done research.
Well, the point I was making was about the origin of, once that origin of the idea is clarified, then who originates the thought beyond, oh, I would like to do this. Or were you waiting for us to tell you how to do it, or have you initiated reach outs for what? Because this shouldn't be sort of a random event after you become chief resident. It should be planned for in the PGY 5 year as the next obvious step. Because we hope to have each of you love your research time, and it opens up the mind to a whole bunch of different opportunities. And where do we go next? And the time to start planning it is not in your chief residency years, but it's the mid or late portions of your 5 year or things of that nature. Just a thought process as we're trying to make this a transition.